Hello everyone, I'm Dr. Anne-Marie Kimbell, National Senior Clinical Consultant with Pearson Assessments. Welcome to today's RehaCom presentation, Attention Deficits and Screenings, created by my colleague Ferry Tomaszyk from our partner company HASOMED in Germany. This presentation focuses on the attention domains and the related neurocognitive deficits and neuropsychological screenings provided by RehaCom's computer-aided cognitive therapy. This is part 2 of our RehaCom series, guiding clinicians who want to effectively deliver evidence-based computer-aided cognitive therapy in everyday clinical practice. If you have not had the opportunity to attend our RehaCom introductory kickoff presentation providing a comprehensive overview, you can find an on-demand recording on our webpage or on Pearson's YouTube channel. Before I start with today's details, I want to repeat some basic information about RehaCom. RehaCom is a comprehensive system for computer-aided cognitive rehabilitation. 28 computerized therapy modules are available to help your patients improve cognitive function and compensatory skills in attention, memory, executive functions, and visual field. The system provides 9 screening modules in order to support the therapist to choose the most effective therapy modules. RehaCom provides deficit-specific, patient-centered treatment. The system is evidence-based and clinically proven. Approximately 70 scientific studies show positive effects across TBI, stroke, multiple sclerosis, schizophrenia, auditory hallucinations, depression, and addiction diseases. RehaCom is suitable for all stages of rehabilitation and can be assigned according to each patient's level of deficit from mild to severe. After starting the therapy session, RehaCom adapts automatically to the patient's performance. RehaCom leads the patient, instructs, and gives feedback. The patient progress is automatically tracked. As the clinician is able to provide services to a larger number of clients, efficiency is also increased. The system is used in clinics, hospitals, nursing homes, rehabilitation centers, and in outpatient services. RehaCom provides both in-clinic and telepractice solutions for treatment. The in-clinic software is installed on your workstation with an optional server licensing solution. The home telepractice solution offers therapy prescribed over secure internet connection for people with mobility restrictions in rural areas or other restrictions on in-clinic visits. During this presentation, I will cover several topics. First, I'm going to provide an introduction to attention and to the classification of attention functions and domains. I will also talk about attention disorders and typical diseases and some symptoms and diagnosis of attention deficits. Finally, I will introduce you to the RehaCom screenings with the main focus on the attention screenings. Let's start today with the question, what is attention? What does it mean? First, a task for you. Please find the blue T on the next screen. Focus your attention on the blue T. The T was easy to find, right? But let's do the same using another type of presentation. Although I couldn't see you, I imagine it took you a little longer to find the T on this slide. From this simple task, we already noticed that there are different aspects of attention. In the previously displayed example, the T stood out clearly. It was printed in bold and had a different color than all the other letters. The T appeared highlighted, and our attention was captured almost automatically. Yet in this presentation, it's much harder to find the T. The stimuli here are very similar, and a serial exploration process has to take place. It's much harder and takes a longer time to identify the T. So the way we experience attention does not seem to be the same. Patients often complain that they have attention and concentration problems. These are common terms. But while it is common in everyday life to speak of attention and concentration, there is evidence that there are multiple types of attention. This has also been shown in our T experiment. Different attention conditions require different attention activities. RehaCom delivers 13 attention therapy modules. This large number of modules is necessary because attention deficits are so common after stroke and TBI. Nearly 80% of stroke or TBI patients suffer from attention deficits. And as you know, a good working attention level is the foundation for all continued cognitive therapy. Even more, as we will see now in detail, attention is a multidimensional cognitive function. We know from decades of research that specific attention deficits require specific cognitive training. Let's walk through the classification of attention functions. This knowledge will help you to use RehaCom in a therapeutically targeted manner. Attention can be roughly divided into 3 areas. Seen here, red shows the attention intensity, orange the spatial attention, and green the selective processes. The ability to stay alert and the abilities to maintain focus and level of attention, called vigilance and sustained attention, are aspects of intensity. These abilities are how the brain is able to provide and maintain attention. The spatial attention is related to the orientation and the ability to shift the focus of attention in space. Focused and divided attention are characterized by filtering processes, or selectivity. Let's begin with a discussion of attention activation. Thank you for your sustained attention, but let's increase your level of attention right now. The definition of alertness is a state of general wakefulness called tonic or intrinsic alertness. Typical tasks to assess optimal levels of intrinsic alertness are simple reaction time measurements without preceding warning stimuli. The term alertness also describes the ability to increase attention, the so-called phasic alertness. The alertness is the most basic intensity aspect of attention, and our reticular activating system is the gatekeeper for this brain performance. The reticular activating system, or RAS, is a network of neurons located in the brainstem that project anteriorly to the hypothalamus to mediate behavior, as well as both posteriorly to the thalamus and directly to the cortex for activation of awake patterns. Depending on how the reticular activating system configures signals, you may be more alert or less alert, more awake or less awake. It helps mediate transitions from relaxed wakefulness to periods of high attention. It controls the overall degree of cortical alertness or level of consciousness, maximum alertness, wakefulness, sleep, or coma. The next one is sustained attention or vigilance. The definition of sustained attention is the ability to concentrate on relevant stimuli over a longer period of time. But the performance depends on the frequency and the intensity of the stimuli. Sounds a bit confusing at first, but analysis has shown that sustained attention and vigilance are very similar, but we speak of sustained attention when we have a high stimulation frequency. That would be the case, using the example of driving a car, if we were to take a long drive on busy streets. There we usually face oncoming traffic, traffic lights, cyclists, pedestrians, etc. So we have to react quite frequently. On the other hand, when driving at night, we may have relatively little traffic and therefore a rare stimuli frequency. But also in this case, we still have to stay attentive to be able to react. This means vigilance. At a glance, sustained attention is the ability to maintain focus and level of attention during high frequency of stimuli, and vigilance is the ability to maintain focus and level of attention to a condition of rare stimuli frequency. You can surely imagine a never-ending list of everyday examples in which you need these particular attention dimensions, these essential skills. Here are just 3 examples. The left picture shows the already mentioned night drive with few stimuli and thus the demands on our vigilance. In the middle, a continuously running conveyor belt where employees are to sort out faulty product components. The sustained attention is required here in case of a large number of faulty parts, and vigilance is required in case of a small number of faulty parts to select. Last, a surveillance task on the right-hand side, a radar control center, which may require both attention dimensions, sometimes a little air traffic, sometimes a lot. In both cases, however, focus and level of attention must be maintained. Let's turn now to the spatial attention or orientation reaction. We already looked briefly at this in our short T trial. The blue and bold T among the black T's automatically captured our attention, while we had to search to find the T in the second array much more actively. The definition of spatial attention is the alignment and shifting the focus of attention in space. This occurs as an automatic orientation reaction or as a conscious shift in attention. We need this ability everywhere. One example is in traffic, but there are many other situations where we need and use this ability. This may occur as an automatic orientation reaction, for example visually, when stimuli suddenly appear when something comes into our field of vision. The brain reacts particularly strongly to moving stimuli or to acoustic stimuli. If suddenly a child screams, then we automatically look around to see what's going on. You can also practice this as a conscious shift in attention. For example, if I'm looking for my glasses or looking for a pen, I focus my attention on different areas of my desk. We come very close here to selectivity. Some theories or classifications do not categorize spatial attention separately. They classify this ability under selectivity because we focus on certain aspects of reality while ignoring or selecting others. Well, that's selective or focused attention. Focused attention, the ability to focus our attention on certain characteristics of a task without being distracted, seems to be simple, but a stroke or TBI patient can often find it very difficult. Some patients find it even more difficult to focus on a specific task while other distracting stimuli act on or surround them. The limited ability to ignore other competing or distracting stimuli makes it challenging to respond and interact always appropriately. The reason is that our cognitive resources are limited, and therefore filtering is required. Various metaphors have been established in science. One of them is the so-called bottleneck metaphor. You imagine our focus like a bottle. We are flooded by countless stimuli, and through our attention filter, ultimately the thalamus, only a small part of the information gets into the bottle for further processing. All other information does not enter the consciousness. Another metaphor is the spotlight metaphor. We imagine the focus of attention like a spotlight in the dark. We notice something exactly where the spotlight shines, but everything else remains hidden. Now we come to the divided attention as the most complex variant of selectivity. The definition here is that attention is split up across different information channels. You have to react appropriately to different requirements or information at the same time. For example, as pedestrians, when crossing the street, we have to concentrate on what's going on in the street, what the traffic lights indicate, and what else is going on around us. We have to analyze it visually, but we also have to pay attention to noises. When the same resources are accessed at the same time, for example, with two visual tasks, large interferences can occur. This can lead to complications. Keeping an eye on several things, reacting quickly but also correctly, already places high demands on a healthy person. When we quickly switch between two or more sources of information, we call it attention flexibility. Now I will provide a brief overview of some of the typical diseases, symptoms, and diagnostic approaches. Regarding the diagnosis of attention disorders, it should be said that disorders of attention are among the most common neuropsychological impairments after acquired brain injury. Attention deficits can be observed in approximately 80% of these patients. A lecturer in neuropsychology once said, "If you don't know what the patient has, just guess attention deficit disorder, and you're most likely right." This isn't entirely wrong. It is a good tip that underscores that it's always essential to evaluate the attention functions in diagnostics. Let's look at the diseases where we can observe attention disorders. We have cerebrovascular diseases and ischemic and hemorrhagic stroke. The majority of strokes, about 87%, are ischemic strokes caused by a blockage in an artery that supplies blood to the brain, and we also have traumatic brain injury. Stroke and TBI both have very pronounced attention disorders. With a TBI, the brain is compressed, and in principle, damage can occur in many areas, and the attention is often affected. Since the attention functions are a complex network, it's not uncommon that even if a primary area, such as the thalamus itself, isn't damaged, it can lead to various attention domain disorders. Maybe the connection to the frontal lobe or parietal lobe became damaged. Other diseases include all inflammatory diseases such as multiple sclerosis or psychiatric disorders such as schizophrenia or depression, which are often associated with attention deficits. And of course, we also consider the childhood developmental disorder, ADHD, dementia diseases such as Alzheimer's disease and vascular dementia, and brain tumors, and this list can certainly be continued. Of course, the first source of diagnostics we have is our patient and his or her self-report. Patients with attention disorders report that they have difficulties concentrating, that they suffer from rapid fatigue, increased distractibility, intolerance to many people or noises, inability to do multiple things at the same time. They report the need to take more frequent breaks from mental activities. Often patients also report that they have difficulty remembering things. But even if patients report memory deficits, it could be due to an attention deficit. Rehabilitation starts with the person with brain injury and his or her family. The personality and lifestyle of the person will influence their needs and desires and the rehabilitation offered. The nature, extent, and severity of the brain damage also need to be determined through neuropsychological investigations. Neuropsychological screenings and assessments enable us to build up a picture of the brain-injured person's strengths and weaknesses, but we should also consider the nature of everyday problems of the patient and the family. We need to know what problems are causing the greatest difficulty, what coping strategies are used, if the problems are exacerbated by anxiety or depression, and so forth. Answers to these and similar questions can be obtained by direct observation in either natural or simulated settings or through self-report measures or interviewing techniques. Overall, the screening and assessment of attentional deficits and the understanding of their clinical correlates are very important. Screenings do not provide definitive comprehensive diagnoses, so cognitive screening tests should not be used as a replacement for comprehensive neuropsychological testing. But it is common for clinicians to be uncertain as to whether a patient is demonstrating behaviors that suggest cognitive impairment. It is important to quickly assess which of these patients are actually demonstrating cognitive impairment that may be contributing to functional problems. Screenings are commonly used for the early identification of individuals at potential risk for conditions or disorders. They may indicate the need for further evaluation or intervention, and they are used to monitor progression of symptoms or response to intervention. RehaCom has 9 screenings on board. The screenings are designed to assist the therapist to find the right therapy modules. They can detect which cognitive deficit the patient may have and which degree of severity can be found. As a result, the system recommends therapy modules most suitable for treating the client's specific cognitive deficits. The direct link between therapy procedures and screenings is really unique, and along with many other sophisticated features, makes RehaCom so beneficial. 4 of the 9 screenings are available to examine the intensity and selectivity dimensions of attention. Here are the screenings designed to measure the intensity and selectivity dimensions of attention. When a screening module is completed, RehaCom recognizes and quantifies deviations from the norm. Depending on the extent of the deviation, the system recommends the most suitable training module or modules. The first screening is the alertness screening. Alertness is the basis for any attention performance and therefore the precondition for adequate action. This screening measures reaction times. The reaction time is measured under 2 conditions. The distinction is made between the tonic arousal, the general state of being awake, presented without a warning sound, and the phasic arousal, which describes the increased responsiveness in anticipation of an expected event, presented with a warning sound. Accordingly, 2 z-values are calculated. A distance from the norm of 2 or more standard deviations indicates a notable severe deficit. A deviation greater than 1 but less than 2 standard deviations, a notable but mild deficit. A distance from the norm smaller than 1 standard deviation indicates a result in the normal range. Depending on the results, the module's alertness and/or reaction behavior are suggested for the exercises. The next screening, called Spatial Numbers Search, is a numeric quadrant. The Spatial Numbers Search screening module is used for testing a patient's basal perceptual processing speed. The patient has to find the numbers from 1 to 24 in ascending order on a grid. The consecutive numbers are not adjacent. The visual search and exploration across the entire number field is necessary. The test can be used for screening of visual neglect or hemianopia as well. 2 additional corresponding screenings within RehaCom are available to provide more precise information about neglect and/or hemianopia. In this screening module, 3 z-values are calculated. For the first z-value, the processing speed is based on the median of all search times. The second z-value represents the maintenance of attention. A linear regression is calculated over all search times. An increase of the regression line suggests that a patient's attention performance declines during the task. The third z-value is based on the comparison of average search times in the right and left half of the screen. An obvious slowdown on one side indicates either a neglect or a hemianopia. As applies to all the screenings, depending on the screening results, the system recommends appropriate training modules. Following this spatial number search screening, for example, the training modules Attention and Concentration, Vigilance 2, and/or Saccadic training may be recommended. After the screenings for measuring the intensity aspects of attention, we continue with the screenings which help to evaluate the filtering processes, the selective attention skills. RehaCom provides 2 screenings to get an idea of the resources and deficits of selective attention and divided attention. Using the screening selective attention, the ability to react quickly to relevant stimuli while under time pressure is tested, as well as the ability to inhibit behavioral impulses when a non-relevant stimuli is presented. The test is based on the well-known go-no-go paradigm. In random intervals, stimuli presenting either horizontal lines or vertical lines appear. When the stimulus with horizontal lines is presented, the patient has to press the Enter button on the PC keyboard or the OK button on the patient keyboard as soon as possible. When the stimulus with vertical lines is presented, the patient should not react. Two z-values will be calculated here, one for the reaction speed and one for the reaction control. The screenings enable you to analyze a patient's ability to control impulse reactions by looking at the number of mistakes. The mean, median, and standard deviation of the reaction times can provide information about the speed of the decision process. Additional information on omissions, outliers, and anticipations is also provided. Depending on the reaction speed and the degree of impulse control, the training module's reaction behavior and/or responsiveness may be suggested. And finally, the screening divided attention is available. The patient has to work on a visual and an auditive task in parallel. 5 circles with openings at changing positions must be observed. When a circle is closed, the patient has to press the OK button as quickly as possible. Synchronously, alternating high and low tones are presented. When the same tone sounds 2 times in a row, the patient has to press the OK button as quickly as possible also. Accordingly, 2 z-values are calculated. The first z-value is calculated for the auditive divided attention. The standard value is the number of auditive omissions, which means the number of missed reactions to 2 consecutive identical acoustic stimuli. The second z-value is for the visual divided attention. Here, the standard value is the number of visual omissions, the number of missed reactions to a relevant visual stimulus. If deficits are measured, the training's divided attention and/or divided attention 2 are recommended as therapy exercises. As an example, here is the view of the spatial number search screening result. All other screening results are displayed in a similar way. The results are displayed graphically along a bar chart. Statistical t-scores, z-scores, and percentile ranks are shown across the top, with the 50-0-50 column representing the average performance of a sample group of healthy people. The patient screening results are shown as gray bars, which begin at the 50-0-50 column and stretch either to the right, indicating above average performance, or to the left, indicating below average performance. A longer gray bar represents a greater deviation from the norm. The background colors indicate the extent of the performance deficit. The red area represents 2 or more standard deviations below the norm, a moderate to severe deficit. Yellow represents more than 1 standard deviation below the norm, a notable but mild deficit. The green column indicates a result in the normal range. The distance from the average is smaller than 1 standard deviation. Screening results are summarized to the left of the graph in the discussion section. The screening module and test are shown, along with the screening date and a summary of results. The recommended therapy modules following this screening result are shown in bold text at the bottom. In this example, the modules Attention and Concentration and Exploration are recommended. On the right side, you find the Print Screening button. This button converts the displayed results into a PDF file that can be printed or saved. The Details button displays a more detailed analysis of the screening results. The Start Therapy Module button starts the therapy module indicated by the screening results. This button is only visible when a deviation from the norm is detected. All results are also stored in the patient's database, allowing the clinician to view the results again later in order to create a specific therapy schedule. The next presentations in this series will provide deeper insights into RehaCom's attention therapy modules, followed by RehaCom's memory screenings and exercises, the executive functioning screenings and trainings, and at least one presentation focusing on visual field screenings and exercises. I want to thank you for your time. If you would like additional information about RehaCom, please visit the RehaCom webpage at www.pearsonassessments.com/RehaCom or email us at rehacominfo@pearson.com.